Good evening, everyone. My name is Janet Gerlach, and I am the Program Director at the Friedman Center for Breast and Lymphatic Surgery in Great Neck, New York. And I am very pleased to partner tonight with the Adelphi Breast Cancer Support Program this evening, along with Northwell Health and the Friedman Center. We have a very special evening tonight to talk about the emotional impact of breast reconstruction. It's a very intimate discussion, and we look forward to having you this evening. I'd like to just go through a few quick housekeeping items. This will be a recorded program. If you prefer not to be recorded, please put your cameras off. We do ask that you also keep yourselves on mute. I'd like to also just encourage you to please use our chat box this evening. If you're familiar with Zoom, there's a chat box function usually at the bottom of the screen, which should pop open a chat box that will usually appear to the right, depending on what version of Zoom that you're in. And I encourage you to put questions into the chat box this evening as you have questions, or save them until the end when we open up the forum for some open and intimate discussion. This program tonight is brought to you by Northwell Health and the Friedman Center with Adelphi, but we also have some other special people this evening that work with Adelphi and with us at Northwell Health, the Manhasset Women's Junior Coalition. Always so proud to be involved with these programs, and we just love them and we appreciate all of their support. In addition to the Northwell Health Cancer Institute, who also supports us in this endeavor with breast cancer, along with the Adelphi Breast Cancer Support Program. So thank you. I'd like to just acknowledge that we have several people here tonight, not only our presenters and our very special guest speakers as patients, but we have many community members that I always like to just give a shout out to and thank you always for doing what you do and just endlessly putting yourselves out there to support breast cancer patients in our greater community. So the format of the meeting tonight is we will go through a very short PowerPoint presentation. We're going to have some very open and honest dialogue with our patients, Dr. Tanna and Angela, who I'll introduce in a moment. And again, I encourage you to please feel free to ask us some questions and use that chat box. I will also put our information as to how to contact us at the Friedman Center. Should you have any clinical questions after the presentation or would like to reach out to Dr. Tanna, we will also put the Adelphi information into the chat box so that you can reach out to them as well anytime. With that, I would like to just introduce Adelphi. For those of you who are not familiar, the Adelphi New York statewide cancer hotline has been in existence for over 41 years. They do an amazing job helping our community in the New York area. We have been so privileged and honored to be able to share a very large portion of our patient base who Adelphi, who's really been amazing to help our patients through some challenging circumstances. They have an amazing group of social workers on staff that are on call all the time, speaking to women in need, supporting women, the underserved community in New York, and also offer bilingual services, which is extraordinary. So thank you, Adelphi, for partnering in this program with us. I'd like to introduce Dr. Neil Tana. Dr. Neil Tana is a plastic and reconstructive surgeon at Northwell Health. He's also the vice president of women's surgical services at Glen Cove Hospital. He is also a professor at the Zucker School of Medicine. So thank you, Dr. Tana, and welcome. And we really appreciate your time tonight being here, especially after performing such a long surgery today. Angela Papalia, Assistant Director, Adelphi Statewide Breast Cancer Hotline. She's a master social worker directing the social work line of women that are just incredible to reach out to women in need. And we thank you, Angela, for being with us tonight. Also a co-presenter with Dr. Tanna. Along with Angela and Dr. Tanna, we do have two patients that are very near and dear to us that we'll introduce a little bit later in the program, who will be with us throughout the evening and through the entire night to the bitter end to offer support and share some of their inspiring stories. So with that, I would like to take the screen share, if I may. Can everyone see my screen? Can you all see my screen?
No, not yet, Janet.
Okay, hold on. Just give me a moment. I don't know why. Okay, can you see my screen now? Okay.
Yes.
All right, so once again, living your best self, an intimate discussion about breast reconstruction and emotional healing for breast cancer patients and survivors. Welcome again, Dr. Tanna, Angela. We appreciate your time tonight and for really putting this program together with us and for us. Just a little bit about the Friedman Center. We're located at 600 Northern Boulevard in Great Neck, New York. We can be reached at the phone number here or emailed. I'll also put our information in the chat box if you would like to reach out to us directly as well as to the Adelphi group. Once again, we have presenting Dr. Tanna, Angela, our two patients. We have Glorby and Joanne with us tonight. And again, I am Janet Gerlach, the program director here at the Friedman Center. And with that, Dr. Tanna.
All right, guys, thank you so much for attending tonight. This is a passion of not only mine, but Angela and Janet and Raina and many people behind the scenes here. And this is for our patients, because we know that outcomes are better when we spend the time to make sure that we are taking care of the entire person. We don't just take care of body parts. We're not here to just take care of a breast. We're here to take care of a person. The event tonight would not be possible without these sponsors. These sponsors are the industry that we work with to deliver the surgery and the results that we perform. And whether we're talking about breast implants or nerve grafts or human tissue or bioptics for monitoring or meshes with BARD, these companies are our partners in the operating room. And most importantly, they've shown responsibility by being our partners out of the operating room. And events like tonight would not be possible without their support and their generosity. So I really wanted to thank them tonight. Janet, is there any way before you move on to the next slide, can you put it into a presenter view just so that the transitions occur?
Sure.
So I think if you just go to view, it should do it all the way to the right.
My Zoom, there we go.
See if it'll do it.
Zoom over.
Who's our tech most person here? I'm already lost. There we go. All right. I think this is it. Let's see. This will do. Okay, perfect. All right. So I think right here, what's paramount to having a discussion like tonight is for everyone to be on the same page and understand what we're talking about. This is an image to the left of your screen of a woman's natural breast. And just going very simply from front to back, you've got the nipple and the areola in the front aligned with the skin. And then you've got the breast tissue right behind that. And then you've got the pectoralis muscle and the ribs. And behind that, which is not depicted, are your heart and lungs. So when we're talking about a mastectomy, what we're talking about, if you go to the next image here, Janet, is removing the underlying breast tissue. And one of the most common questions we get is, or the misnomers is, are you amputating my breast? And we're not, so the thought process may be, when you hear that you need a mastectomy, that, oh, we're removing the entire breast and just amputating. That's not what we're doing. We're going in and removing the inner contents and leaving that outer shell. So next image really depicts what is left. That's essentially what is left. And how we fill that inside, leaving the outer shell, is breast reconstruction. So the next will basically summarize what are our options. As plastic surgeons and breast surgeons and physicians who take care of patients who are considering a mastectomy, this is sort of our toolbox. So the way to fill it at the top is with an implant. And that's basically placing an implant behind that shell of skin. This is important to recognize that it's very different than a cosmetic breast implant. Another common misconception is to think that implant placed for breast reconstruction following a mastectomy is the same as a cosmetic breast augmentation. It's not, because in a cosmetic breast augmentation, you're placing an implant behind the breast tissue. And we already said that in a mastectomy, the breast tissue is removed. So in that top diagram, when you choose an implant, and it's often a tissue expander then followed by an implant, but that's ultimately what you get. You're having an implant placed underneath that skin envelope with no breast tissue. All the way to the bottom of your screen is what's called a flap. And a flap is essentially using a woman's own tissue to reconstruct her breast. And very much like the computer screens or the tablets that you're looking at or anything that requires a plug to charge, when you want to charge that, you have to take it to a plug and plug it in. And the same concept applies with your own tissue. When you are taking a chunk of fat, you need to take it on blood vessels. And that blue and red are the artery and vein that supply that. And the latest innovation is that there are some women who have some extra fat, but maybe not enough to build the desired volume. And they can be a candidate for what's called a hybrid. And that's essentially an implant and a flap. And that's all the way to the right of your screen, having the implant and the flap there. And what's nice is today you're going to hear Glorby's story and journey, and she's a patient who had a flap reconstruction. And you're going to hear Joanne's story is a patient who had an implant reconstruction. And it's very important to understand that breast reconstruction in 2022 or in modern times is one of options. And that's a great thing as a patient. As a patient, you can feel frustrated with the amount of options, but I always look at it as it's a great thing to have options and choice, because that is ultimately what is empowering. So next slide. Actually, go back one slide. So with that said, I wanted to show you that not every woman's body type is the same, nor is her preference. And I'm about to share 3 screens that can be graphic for some, but they're just real life examples. And these are going to be before and afters. And what these before and afters don't tell is the journey that happens in between. And that's why events like tonight are critical, because it tells the story in between. It tells Glorby's journey and tells Joanne's story. And that's why having support from people like Angela and Raina and others on this call are critical, because it's the journey in between, and no photographs that I can present tonight can capture that journey. So again, these are some graphic photos, but this is an example of these are just implant reconstructions. These are placed underneath the skin, and you can see the varying degrees of results, and the patient, all the way to the bottom right that has a star is a woman who couldn't have a nipple sparing mastectomy and instead had a skin sparing where the nipple was removed and only the skin, versus the other 3 women had the nipple and the skin, the entire outer shell preserved. Next slide. So the next slide is the flap. This is the one using your own tissue. And, you can just see, again, different body types and different preferences. And actually, the patient in the top left is a patient who had an implant reconstruction and thought that she had to live like that and didn't understand that, oh, I have an option to have it redone. Insurance will cover it. A lot of questions that these pictures don't tell you. And the last is probably our newest form of reconstruction. And these are women who wanted to have some form of their own tissue reconstructed, but were either too thin, meaning didn't have enough fat, or wanted breast volume that didn't match up with the amount of fat that they had. So these are women who have a combination of their own tissue and implants. And the point in showing you this is that each woman's journey and each woman's medical treatment plan is going to be different. Just like we all have preferences for ice cream. Last night, my wife said, I want vanilla. I said, I want chocolate. Why would anyone want vanilla? It's the same concept here, is that we all have preferences as humans and individuals, and we have to respect that. And that's really the crux of giving these slides. I think next slide.
So
perfect. So I
I'm
think,
going to just
yeah,
pause there for a second. I'm going to stop sharing the screen. We're going to just go into a little bit of conversation. Dr. Tan, I'll start with you. You know, sometimes women don't know what they want in terms of reconstruction, and it's all so very overwhelming when women come in and they hear about all these options. And it's not a one size fits all approach. There's so much to know. Where do you start with the patient that comes in and knows nothing about what her options are?
yeah, I think, we have to start very basic, and we explain to patients that, the first thing is to come to terms with having a mastectomy and removing the breast. You have to stay strong to that and decide, are you doing one breast or both breasts? And then ultimately, we want patients to express their desires. We want them to understand that they can tell us, how big do I want to be? Do I want reconstruction? Do I not want reconstruction? And then it's all about us spending time with patients to really explain to them what the options are, and then try to marry those options to their preferences. And preferences, not only body type. We're talking about even, a woman with young children versus someone who's retired versus someone who's thin versus someone who's an active lifestyle, someone who works two jobs. All of these women are going to have different preferences as it pertains to their ability to tolerate risk and recovery. At the end of the day, what I would say is that, as a practitioner, we want to educate women, just like we did in these few slides. We want them to utilize their resources, and those resources are come in the form of, obviously, online resources. They come in the form of other patients. And that's what, again, events like tonight are, to connect other patients. There's no stronger source of that. And then, our support network like Adelphi. So I think that between those resources, patients should be educated.
When is the best time to have breast reconstruction?
I would say that the majority of time, the best time to have reconstruction is at the time of mastectomy. Study after study has demonstrated that there is a benefit to having immediate reconstruction. What that means is at the same time as the mastectomy, having immediate reconstruction. There are a few times where we sway away from that. And that's essentially if someone has, let's say, a very aggressive form of cancer, we're getting them onto treatment, chemotherapy, radiation, following surgery is critical. Then we may say, let's do a delayed reconstruction, meaning let's do it after the mastectomies, after you've healed, because we want to do the least amount of surgery so that that patient can get onto chemo or radiation. Mm-hmm. The other times is, let's say a patient just has too many comorbidities. They're just too sick with what's going on to tolerate the risk profile. In those few instances between those two times, we'll tell a patient. But I would say the majority of time is at the time of the mastectomy.
Mm-hmm. And I know you touched on this in your presentation, but the hybrid breast reconstruction is something that's so new on the block. Not all plastic surgeons even perform hybrid breast reconstruction procedures. Why has it been becoming so much more relevant to the patients that you see? Why did it come to be?
Yeah, because it basically gives another option to patients. In your traditional algorithm where you had a patient who just was either an implant or a flap, it was actually it was black or white, and there was no in between. And so you'd have patients who were kind of stuck in the middle and saying, like, I want this breast volume. I want to be the same size as I am, or I will tolerate even a 25-30% reduction. And I have some fat to use, and you're telling me that I either use what I have and be much smaller, or go on to an implant only reconstruction. So it really developed out of patients' frustrations with what was existing. And then the second thing was, we started noticing that a lot of patients who had implant reconstructions would compare themselves to breast augmentation patients. I had a girlfriend, I had a friend, a cousin who had a breast augmentation. Why do they look better? And again, having that soft tissue breast in front of the implant makes a big difference. And that was the other impetus to create the hybrid reconstruction, to create a more natural appearance and a more natural feel.
Mm-hmm. And how does a reconstructed breast compare to the opposite healthy breast? If a woman decides to have a unilateral breast reconstruction, what can she expect? And will anything need to be done to the healthy breast?
Yeah, that's one of the most common questions that we get is, at the initial consultation is, I'm choosing to do one breast only. What does that mean for the opposite breast? The first thing they need to understand is that it is a woman's right. It is her something done on the other side if she chooses. If she says, you know what, I don't want to, then there may be some degree of asymmetry. You can't expect having an operation or reconstruction on one side and it being perfect to match on the other side. You know, as life goes on, the breast may develop ptosis, which is sagging, or changes, and it becomes very hard to match it. So a woman can have a lift or a reduction on the opposite breast, the healthy breast, to match the reconstructed breast. You know, or sometimes as simple as, oh, I literally saw a patient yesterday who said, I didn't know I was entitled to have the opposite breast mastectomy, because many times a double mastectomy with reconstruction feels or looks more symmetric than just one side, even with the symmetry procedure. So, you know, it's important for women to understand that they have the right to do nothing, but quite similarly, they have the right to have a lift or a matching procedure, or even have a mastectomy and reconstruction on the healthy breast.
You know, we have two patients tonight with us that had two very different types of procedures. And I think, you know, one of the things that we see so often in our office is, you know, for a woman that has this idea about what she wants may or may not always be the right fit. So, you know, why is it so important to really explain to these patients? For instance, I know we've had patients come in that, you know, want a deep flap, but you know what, sometimes they're just not that candidate, or vice versa.
Yeah, I think, listen, I think it's like a marriage or a partnership, like anything in life, and it's trying to find the best fit. And what patients have to understand is that there's advantages and disadvantages to each approach, and there's risks and limitations. And it's about managing those advantages and disadvantages for that individual patient. Mm-hmm. So for those of you that are listening, you're going to meet two amazing women. They're inspirational to so many of us and to myself. And you're going to see that, for each one, their journey was different, but it worked for them.
Right.
And like anything in life, it's what is the best for them where they are in their life. And I think for any of the women out there, they have to understand that this is not fixed in a time point where that decision is forever. I mean, what is forever in life? Nothing, right? So what is, so the same thing is that, one of the most common themes we see is that there's this pressure that, oh, if I choose this, I have to stick with this. And very commonly we have patients who have revisions or do switch or go from an implant to a flap or add an implant to a flap or whatnot. So I think you'll see that it's at any moment in time, it is about matching what is available with an understanding what the limitations are to that patient's preference and her body.
So speaking of, I'd like to introduce our first patient guest speaker, Glorby. Thank you for being with us, Glorby. Glorby is 36 years old or thereabouts last year when she was diagnosed with breast cancer. She did proceed with a double mastectomy and a deep flap reconstruction. Glorby also has a young daughter who she has shared her journey with very openly and in a very inspiring way. Glorby, thank you so much for making the time to be here. I know you were just getting out of work to get onto this webinar with us, so thank you. Take us back in time. What was it like living in the moment when you were diagnosed with breast cancer last March?
So when I got the phone call, I was food shopping. I was just getting out of work, my normal routine, and I get the phone call, and I was in total shock, total denial. I'm like, no, are you sure? Did you check it right? I immediately went home, broke down. I started to worry, to panic about my daughter. How bad was it? I didn't know how severe it was, but after a good hour or two in the shower, took a deep breath, and I was like, okay, time to take the bull by the horns and see what we have to deal with.
Then you proceeded a few months later with breast reconstruction with Dr. Tanna and had a deep flap. how did you remain positive through your journey? And, perhaps even, sharing a little bit of inspiration with how you approached your daughter about it. That's such a common question and fear that we hear from a lot of moms out there, is how am I going to tell my kids? It's such it's so stressful. And Angela, I know you help patients through this all the time. So Gloria, what kind of inspiring words can you give us about that?
I have a very close relationship with my daughter, so I didn't try to beat around the bush. I told her, I went to the doctor and there was a chance that it may be cancer. And she's like, so what did they say? And I said, well, I do have cancer. Her response was, are you going to die? After crying. And I'm like, no, that's not what that means. It just means that it's there and we have to take action right away, go to the doctors right away, but everything's going to be fine. We're going to be fine. I kind of changed my panic mode to a positive because I didn't want her to see that fear in me and have her worry even more.
Mm-hmm. Angela, what are some of the things you help coach women to build resistance through this breast cancer journey?
Well, one of the things that we always say is that it takes so much courage to ask for help. And it's absolutely a sign of strength when people are able to mobilize and pick up the phone and say, I really would like to talk to somebody. So we believe as social workers in the strengths-based perspective, which means that every single person has unique strengths inside of themselves. And we draw strength from who that individual woman is. And we use those tools to help her navigate through her journey with breast cancer. And that just means some days literally taking a deep breath, taking another deep breath, and putting one foot in front of the other and staying in the moment and having somebody there to just say, let me hear what's going on for you. Because women wear so many different hats and women are so many things to so many people in their lives. So often, even going through a breast cancer diagnosis, we hear from women all the time on the hotline and all of the social workers saying, I just haven't had a chance to talk about this. I haven't had an opportunity to cry because I'm in this whirlwind that I never expected in a million years to be in right now. And yet here I am and go, you're rushing, you're going to these appointments and this doctor, and you feel like the whole world, the carpet has just been pulled out from under you, but you still have to do all of these things, right, to take care of yourself and your family. So we're here to slow down and to really look at who each individual person is, what are her unique needs, and how we can best help support her and her family, whoever that means to you, whoever is in your life, to help get through from one day to the next.
And, it's so important to have that psychosocial support because there's so much on the clinical side that patients are trying to absorb at the same time. And it's really a very multifaceted healing approach and process that one goes through. So Dr. Tanna, on the clinical side, with Glorby's surgery, having a deep flap, it's a pretty big operation. It's been so vastly, improved and enhanced through the years that I think the recovery is far superior than it used to be. But even so, it's still, an intimidating surgery for most women. What are some of the things that you can share with our audience about how to optimize recovery through a deep flap from a clinical perspective? You're on mute.
Sorry. I think, it's very important for everyone on this call to understand is that, we as clinicians want to be better than we were yesterday. And we're always thinking about how we can be better. And that's really should be in any industry, right? And in the deep flap surgery or any breast reconstruction surgery, we have gotten so good at certain elements that we really are pushing the boundaries on what other things can we improve upon. So, you focus on the aesthetics and you say, okay, well, we can do a breast reconstruction that looks very much like a natural breast, but what else can we do? What about their pain? How do we minimize their pain? So, that's been the impetus and the focus for the last few years, is saying, how do we minimize their pain after surgery? Because we know that narcotic addiction occurs from opiates prescribed at the time of surgery. So we've shied away from that, and we use, pain blockers. We use long-acting numbing medicine, and we, have figured out how to numb nerves for days so that patients are able to get out of the hospital in a day or two.
Continuar.
And so it's been a focus
Entonces
on those
el
aspects
enfoque
of recovery. The other
en
thing is understanding a support network. I think it's really important to have that support network at home, whether it's family or friends. And it's not just a physical network, it's the psychosocial, which, Angela and Janet have touched upon. So those are the sort of elements that we're now focusing on. It used to be on just the aspect of building the breast, but now it's looking at the entire person and the elements of pain and how do we make someone feel whole again.
Mhm. Speaking of looking at the entire person, I'd like to introduce our next patient guest speaker, Joanne. Thank you, Joanne, for being with us tonight. Joanne has a very interesting story. She has a very strong family history of breast cancer that goes back decades, from her mother to her grandmother to her aunt on her mom's side. Joanne was genetically tested and tested negative for the very known mutations such as BRCA and some of the other ones that are beginning to be more understood. But her DNA did come back that she had Lynch syndrome, which puts her at a very high risk for breast cancer. And so Joanne proactively fought to have a double mastectomy to avoid getting cancer. And with that, she got a lot of pushback from her insurance company at the time. Lo and behold, may have been even a blessing in disguise. Joanne found a nodule in the process of fighting with her insurance company. And at that point, Joanne finally got approved to have a double mastectomy and sought out her options about breast reconstruction. Joanne elected to have a nipple sparing implant procedure with tissue expanders. She went through a good 2 years of a recovery process. Joanne's also a single mom with 2 sons that she shared her journey with. Joanne, you had a long history of breast cancer in your family. Can you give us some background about what prompted you to actually go for genetic testing, which is sometimes intimidating for some to want to know that information?
Sure. First of all, thank you for having me tonight. I always love to share my story because I think it truly brings awareness, and it brings awareness to being on the proactive side. Because when we're faced with breast cancer, sometimes we don't have choices and we have to do what we have to do. But my end was the complete opposite. It was being proactive. And I've had it, like you said, a very strong family history. And I just knew it was coming down, and I was under the watchful eye of Dr. Caddison already, because it was my aunt. Well, my grandmother had it twice and had succumbed to it the 3rd time. My aunt then had it. And then unfortunately, I did lose my mom in a very traumatic way. So my mom's fear then propelled me to fight. I knew that I didn't have a choice but to step into this. And I'm an Aries, and I always say I use my horns. I had to plow forward. There were 2 roads that I was either going to take. One that would say I'm going to sit back and I'm going to wait for this to get me, or I'm going to fight to beat this. And I chose to fight it. Mm-hmm. It was a very long, hard fight. And like you had said, I did discover a nodule, which then a lymph node popped out under my arm at like 3 o'clock in the morning, and I was numbed with fear. And I kept saying, oh my God, it's here, it's here, it's here. Thank God it was not here. It was some atypical cells that were pulled out. But we fought. We at that point, the insurance companies, they could not tell me no anymore. I went through everything that they asked me to do. I did the genetic testing, like you said, discovering the Lynch syndrome. This was definitely coming from the maternal side, obviously. And I did it. We fought hard, and I surrounded myself with incredible doctors that gave me the options, which helped really truly guided me.
Yeah. So I know you shared with me, and I know Joanne for several years now, and you have shared that you were frightened to have the surgery, but you were also frightened not to have the surgery, in fear of getting cancer. But in your fear of, having surgery, you really triumphed through to becoming an amazing patient advocate in the end. But what is it that you were worried about, with having the surgery? I know you had spoken to me very intimately about body image issues, and just, how you would feel as a woman. How did you get through some of those fears and moments at such a tender time in your life?
So I guess some of it goes back to the memory of my grandmother.
Creo que eso regresa a mi memoria de mi
When she had
abuela.
breast cancer was back in the
Tuvo
70s.
cáncer en los 70s.
Reconstructive was reconstructive surgery really almost wasn't an
Era,
option. Wasn't an option at
casi no
that
era una opción para ella.
time. So I'm sorry, can you
Entonces-
hear me?
Yeah, we're getting the interpreter in
Okay.
for some reason.
I'm sorry
So,
for trying to.
With my grandmother remaining flat, I always had that imagery of her, which never made me look at her less than a woman. With that being said, when it became my choice of, we all have choices, we do, and there are some women that do choose to stay flat. For me, I'll be honest, I'm a vain person. I was a single mom, and I think that was more of what propelled me to choose to take the reconstructive route.
Mhm.
I was afraid of staying, flat in the sense, and I wanted to feel like a whole woman again. I truly didn't want to, again, I knew that was going to make me feel whole again. So this is the route that I knew that I had to go. And there were no choices to be made at a certain point. It was just do it, and I kept putting that in my head to just plow forward.
Dr. Tanna, on the clinical side, I'm sure it's not easy for you when these women come to see you and, the thought of losing a breast is, first and foremost in their minds. How do you approach this, real sensitive topic about losing a breast with your patients?
Yeah, I mean, I think it's very important. That was the reason why I showed those slides. It's very important for patients to understand that losing a breast is losing an organ. If you had a patient in front of you that lost a kidney, right, lost a lung, it's no different losing a breast. And I think that there's a few elements that surround that. Number one is that, it's to reconstruct a breast after it's lost is not something that's going to happen instantaneously, and that's why I frame that sense in an organ, like Glorby and Joanne, there's a lot to their journey, the visits to the office, the sutures that had to come out, the drains that they had, and that's just the medical side, not even there's the psychological aspect. I think the other aspect for these women that come in is more often than not, women are the CEO, CMO, CFO, everything of the house, right? They do everything. So when it comes time for taking care of themselves, I admit it. I admit it. And for them to, they just to stop for a second. It's hard, and acknowledging that. But you got to understand, if you're losing an organ, you got to give your body that chance to recover, right? It's no different. Someone takes out a kidney, or loses a lung, you tell them, whoa, relax, take it, and it's the same thing, and I would say that last thing goes to family, whether it's a spouse, a partner, or a child. They may not take it seriously, and they should, though. That's the thing, is because losing a breast, a mastectomy, is a real deal. It's not some simple thing, some psychologically or physically.
Yeah. Angela, on your end, finding, out women finding out they have a genetic disposition to developing cancer, or even worse, having a cancer diagnosis, brings on a whole host of psychological, psychosocial aspects of what women have to deal with. other than self-image, which we know is huge for women, what is it? What is the crux of what you deal with women on your end?
I think one of the most important things that we do is provide a safe space for women to talk about the things that are really terrifying and they're so real. You know, women's fears about intimacy, relating to your loved ones, to your partners, and most importantly, how we relate to ourselves. You know, accepting our bodies and accepting a new normal. What does that look like? You know, kind of making peace with this body that has changed and may not look the same as it did before. And being able to express yourself in a way that a lot of women often just don't have that opportunity. You know, it's a wonderful place to bring those kinds of fears and concerns when you meet with a social worker in counseling, in individual counseling, but also our support groups, to be with women that we really tailor our groups specifically for women who are going through the same part of their journey as you are. We also have a peer-to-peer program on our hotline, which matches women up. So, for example, if someone's going for a bilateral mastectomy with a certain type of reconstruction, she can actually talk to somebody who's been there, who understands what it's like to be in that moment, you know, asking the surgeon, what are my choices? What does the recovery look like? What is it going to be like after? And to really be honest and to have a safe place to put those feelings and fears and to be validated. And certainly your treatment team is a wonderful resource to not be afraid to ask every single question and then ask again after that first visit. You know, what should I expect? I know you told me 1,000 different things last Tuesday, but now it's this Thursday and I can't remember because there's 1,000 things in my head. You know, to not be afraid to communicate with your treatment team. Very, very important. And you're the most important person on that team, to not forget that. The patient is the central person, the MVP.
It's a perfect segue to get back to Gloria for a moment. Glorby, rather, sorry. Glorby, you shared a very intimate discussion with me about your concerns in the bedroom with your husband, being very fearful of even approaching that topic, worried about how you would not only feel about yourself, but how your partner would feel about you. I know we talked about, being scared in your new body, but somehow you did it. You are a vibrant, beautiful woman as a result. Tell us a little bit about what that was like for you and how you transformed.
So it did take a while. I wasn't ready for a while. And I even told him, listen, if you want a divorce, I get it. I'm not going to be the same. I'm not going to look the same. But I have to say, I'm like the luckiest woman. This man is so patient and so caring. He said, I'm not going anywhere. I'm not leaving. I'm here to support you no matter what, whenever you feel ready. He said, they look the same. They feel the same. So even if you don't feel them, I feel them. That's good enough for me. And he just made it so comfortable. And when I finally did, I have to tell you, it didn't feel any different. I didn't feel any different. He didn't make me feel any different. And for that moment, I forgot. I forgot how I looked. I forgot what I had. So it did scare me for a little bit, but he just made it so much easier for me to accept it and accept myself the way I am.
And so now that you're, coming up on a year anniversary since you've had your deep flap.
Yeah.
How has Reconstruction changed your life?
Honestly, it changed me for the better. Like, I learned to value myself and love myself. Like, I have no regrets with the surgery, no regrets as to like, for example, I tell people that I had breast cancer and they don't believe it because I don't look like I had the surgery. But with this reconstruction, I kind of saw it more as my little reward for what I went through, getting my body back to I guess, as normal as I can when cancer first happened. I don't know. I just, I'm like a little like frozen right now because it helped me a lot. I don't know. I kind of froze a little bit, but it just helped me a lot in the sense of accepting myself, loving myself. Going forward, I'm not going to let this fear me the way it did, I guess, if that makes any sense.
Well, I'm sure, Joanne, you can relate. Joanne, having gone through her implant reconstruction, also shared those very same fears and emotions. And I have Joanne's permission to share her story about dating again, and how anxious she was about that. And how would she even think about dating again after her breast reconstruction? Joanne, can you share a little bit about that with us?
Sure. That was probably my biggest fear over the mastectomy. I was, a single mom for many years. And, throughout the surgeries, I really was actually packing on some weight. Not only was I having these problems with, my body imagery with the expanders in, I began to get heavier, and I had no confidence in myself. And my girlfriends would say, you have to start dating, get your feet wet again, and, put your feet in the water. And I thought they were crazy. And I did. I went out on a couple of dates, very self-conscious. I wore clothes to camouflage, for people who don't really know about the expanders, as the process goes, you tend to get bigger and bigger and higher, and it's only a temporary. And I knew that. But for me, I was so self-conscious. And so that was one of my biggest fears. And fast forward, the surgeries were done after the long 1.5-year journey, and expanders came out and implants went in, and I began to feel better about myself, losing the weight. And then this amazing, wonderful man comes along, and I'm like riddled with fear. Like, oh, what do I do? I really sincerely, that's how I felt from the first night that I met him, because when I met him, we connected. And to make a long story short, I was open and honest with him my first date. And he, till this day, appreciates that. I told him my fears, that I had just gone through this journey. And he said to me, well, if it makes you feel any better, I would have never known by looking at you, just like Gloria just said, which made me, extremely happy. But it was a process. I'm going to be upfront and raw. It was a process. I stayed covered for many intimate moments until that one night when I finally I let it go, and it wasn't as bad as I thought it would ever be. It was a relief. It was a relief.
Angela, you must hear this a lot on your side, with women who are fearful of going back to dating or back to, a level of intimacy that they once had.
Absolutely. And I just have to say to Gloria and Joanne, thank you so much for sharing so courageously, because it's so real, and it's what so many women go through and experience, and it's hard to find a place to talk about it. So really, thank you. And, what we say to women is that, you can do this. You deserve to love yourself and to be loved. And the process and the journey of accepting yourself in this kind of new beginning, right? We consider it a new chapter of your life. It's something that you don't have to do alone, that there are people to talk to about it, and you deserve to be happy. You are the sheroes and the warriors that have been through so much. And more than ever, this is a time for you, all of you, to feel desirable, to feel loved, to feel beautiful, to feel good about yourself. And sometimes during the journey, when it's arduous and challenging and painful. Some moments when you're going through different types of reconstructions and surgeries, it's hard. It's really hard, but it can get better. And there is a light at the end of the tunnel, and you absolutely deserve to be happy. And we fully support everyone on that journey, and it looks different for everyone. And there's no timeline that's the right time. It's your time is the right time when you're ready. And we say, poco a poco, little by little. But we're here to be a part of that journey, and it is possible.
Both Joanne and Glorby shared with me how at the onset, they were very concerned about loss of nipple sensation, which does happen through the breast reconstruction process when you have a mastectomy. And, there's been some advancements made. I'm going to play a quick video, and then maybe Dr. Tanna, maybe you can talk to us a little bit about nipple sensation and breast reconstruction.
Life after mastectomy.
Oops, sorry about that, guys. Hang on.
Life after mastectomy can be overwhelming. Nerves cut during the procedure can leave your chest feeling numb and have you missing out on important signals and loving moments. It's frustrating because how your breasts feel to you should be as important as how they look. But now something can be done. Resensation is a surgical technique that can happen during your reconstruction following your mastectomy to potentially restore the sensation in your breasts. During natural tissue reconstruction surgery, nerves that were cut during your mastectomy are reconnected to the nerves in your newly restored breast using processed allograft nerve tissue that over time becomes part of your body, so you can feel like you again. If you're facing a mastectomy or breast reconstruction, visit resensation.com to connect with a trained surgeon near you.
Dr. Tanna, can you explain to us a little bit about what that is and where we are?
Yeah, this resensation, represents an innovation that is taking us forward. Like I said earlier tonight, it's not just about making a breast that looks good. It's about how do we do that in the least amount of pain, the most emotionally sensitive way, and hopefully return some degree of sensation. The nerves to the breast run, from the outside of the chest and from the inside of the chest. And essentially, removing that breast leaves severed ends to those nerves. And, the video that you saw is an innovation that allows us to use nerve grafts, cadaveric nerve grafts, meaning from, human donors, and basically bridge that gap and give the potential for sensation. And so it's just another step in the right direction when we're looking at, breast reconstruction. What is the ultimate goal? And again, it's just to reiterate that it's not about the appearance. It's about the appearance, the feel, the process, the journey, all of those elements. So it is a nice advancement in the field.
Mm-hmm. And who qualifies for this kind of thing? Is it every patient? Is it a select handful at this juncture?
Yeah, it's anyone can qualify. It's just a matter of the the surgeon and the patient having a good discussion about who's going to get the best result. Obviously, a patient who's having this done at the time of a mastectomy is going to be a little bit more favorable than one that is in an area that's scarred up or radiated. But again, that doesn't mean it can't be done. It's just a matter of, having a discussion about, what is being, what other things are being done in terms of the reconstruction. Is it an implant? Is it a flap? What is the, do they have radiation there? So available to anyone, just having a discussion with the surgeon about it.
Thank you. I know it's so important to keep moving in that direction, as it's a game changer for women, in the future of breast cancer surgery. Gloria, I want to get back to something that we had discussed early on about your having children. You have a 13-year-old daughter, right?
Yeah.
And you were not sure whether or not you'd want to have more children when you were diagnosed with breast cancer. And you were faced with some fertility challenges or just some things to try to figure out. What can you tell us about that?
So my husband and I were trying to get pregnant from the moment we got married. We already had fertility issues going on. And during that time, we were actually seeing the fertility doctor for possible IUIs, and we had a few failed IUIs. During that time where I found that lump, which turned out to be breast cancer, Dr. Tanna suggested that I do a round or two of IVF to either freeze my eggs or freeze the embryo before any treatment. And I said, well, I can't afford IVF. I've been doing IUI because Northwell covers it. I can't do this. And so talk to them anyway. I'm sure with breast cancer, it falls under a different bracket or whatever. So I did. And sure enough, when you go there to freeze your embryos or eggs because you have breast cancer, it is different. It's completely a different price. And there is a company that helps you with free fertility medication, as opposed to everything coming out of pocket when you're doing it, in other situations. And so we did our first round right before the surgery, actually. We actually had about 4 embryos, but only 1 made it. And that's good enough. We only need the 1. But yeah, if it wasn't for that and the company that helped with medications, I wouldn't have anything right now. I think it would have been a done deal because we had to get the ball rolling right away, get the surgery right away. So if it hadn't been for me to do that in the beginning, my chances to try to conceive after could be very, very slim to none. So I was very lucky that I was able to do that.
Dr. Tanna, on the plastic surgery side, we tend to see, every once in a while we get a very young patient. We see lots of women in their 30s, some in their 20s in some cases, who have not had any children yet, but need to have breast cancer surgery and are interested in breast reconstruction. How do you advise those young ladies? And I know I get a question all the time about, if I have a preference to a deep flap, does that mean I can't deliver a baby? How do you answer that one?
Yeah, I mean, that represents one of the common myths. I mean, there's so many myths out there. That's one of them that, can I get pregnant or have pregnant, can I carry a child after having a deep flap? Absolutely. It's the same as a person who's never had a child. The fetus will expand the abdomen and allow for it. And we've had many of our patients go on to have pregnancy after, because you're right, we do see younger and younger patients. But it is a myth, just like, I need to have my implants replaced every 10 years, myth. Or, does breast reconstruction covered by insurance, myth. I didn't know the opposite side isn't covered, myth. Or I'm too old for reconstruction, myth. Or I'm too unhealthy, just a bunch of these. I think the most important thing is just to make sure you see qualified surgeons that can give you the best advice.
So Joanne, you were very articulate in that part of your journey was so successful because you had a dynamic relationship with your medical team. Why is that so important? How did that impact your journey? Because you obviously came out on the other side being so very happy with how you look, how you feel, and you have no regrets.
It's so important. I think from the day that I met Dr. Tanna, he was always straight up and forward with me. He told me what the best options that he thought worked for me. I asked him, to tell me, because I really was clueless. Having that open relationship where you can speak to your doctor about anything is probably the most important thing that you're going to do in this reconstructive journey. If I had any questions, he answered my calls. He always reiterated that, you know, nothing, like he said before, is final. You know, you decide. We have to see what the best fit is for you. What are you comfortable with? You know, the questions I probably had were endless. But one thing I will say is you also have to have a team who is extremely confident. And from the day that I met Dr. Tanna and his team, there was nothing but compassion, empathy, sympathetic, sensitivity to my feelings, how I was feeling. I remember numerous amount of times, how do you feel about that? He would say to me, do you have a question? He would, you know, he knew what I was thinking, but half the times I didn't even know what I was thinking. You know, the first time that I met him, I got into the car and I was like, what was that? You know? So, it's so important to be able to have this open, like, forum, so to speak, that not to be afraid to ask questions, or maybe you're going to feel stupid asking that question. You know, you're not. You have to look out for your best interests, and you have a right to ask questions.
I know you had also mentioned, you know, when I asked you about, you know, how did you get support? Your first answer was through your team. So for you, being a single mom and kind of staying a little bit solo and not broadcasting what you were going through, you relied on your medical team for support, which was amazing
100%.
that they were there for you. Gloria, you had a very different experience. Your medical team was there for you, but you also relied on other resources. How did you get support through your journey?
So I got support, my family foremost. And I also looked at there were two groups on Facebook. One was, I think it was New York Breast Cancer. And then there was another group page called Babies After Breast Cancer. And I got in there with so many women who are going through the same thing I was going through or already went through it. Some women had the double mastectomy with deep flap. So I was like back and forth between both groups, and a lot of questions, and a lot of their experiences were kind of similar to what I was experiencing. My family, of course, were there when I would just have a very depressing day, when I felt kind of doubtful. And like she had mentioned, Dr. Tanna never lets you leave the office until all of your questions were answered. Are you sure? Do you have anything for me? Are you positive? And Brittany, love Brittany. She is amazing. If I had any questions, even on a weekend, I would email her and she'll email within seconds. So overall, I had the best team ever.
Yeah, I'm just popping up a few pictures of your beautiful family, Gloria, and your partner, who you speak so highly of, who has been such a big part of your journey. And you can really see how Gloria stayed so positive through her experience, and not only with her partner, but how she really involved, you know, children, and, you know, did some fun things. You know, the loss of hair through this journey is something that, you know, women just get so depressed over, rightly so. And you somehow made it fun. How did you do that? How did you find the strength to do all these fun things when you were going through such a hard place in your life?
I had the kids ask me so many questions. Like, they were so afraid for me when they came home to see me after being discharged. And they were like, why do you have all those tubes on you? And why is your hair falling? Are you so many questions? And I'm like, you know what? If they're afraid, I don't want them to feel scared. So I don't know what came of me. I decided to just snap out of depression, snap out of just, you know, everybody's like, oh, you should try a wig. And I'm like, no, it's the summer. Oh, you should wear these little covers for your hat, you know, for your head. And I'm like, why? This is what's happening to me. This is what I'm going through, and I'm going to embrace it. And
For
I
you.
kind of missed the bald head, I'll be honest with you. So I just went to the store, I bought paint, I had the kids come, and I'm like, knock yourself out. You know, some of them call me Uncle Fester. I'm like, okay, you know, whatever makes you happy. But I have to say, by having such a positive attitude, I think not only for them, but it helped me on my bad days of chemo. I didn't think of the pain. I didn't think of the bone pain. I didn't think of the medication, the nausea. It was just overall a good time. So they helped me, even though I let them paint my head, but it was helping me emotionally to get through it.
For both Joanne and Glorby, if there was one thing to share that, you know, if you wish you had known something before that you know now, what would it be? What would it be, Joanne?
So for me, I guess I come from a different aspect, being again a single mom. Planning is key, especially I worked 7 days a week. I'm sure Dr. Tanna will remember what I said. I went back to work with a couple of drains stuffed in my leggings. I plan, get your support system together. It is key. And for me, I didn't have it. My mom was gone. I had boys. I didn't even have daughters because I felt it was a little more personal when it comes to having a son. You can't take them into the bathroom with you. Maybe whereas opposed to a daughter, you could. So that was difficult. My dad was elderly. Some of my family really kind of turned their backs on me and said, didn't agree with what I was doing. So for me, when I talk to other women, I say, have your support system ready. It is very important. So that was a struggle for me, but that is where I constantly leaned into Dr. Tanna. He was the one who never showed me fear. And I learned from the bottom of my heart, and he knows how I feel, I learned how to shelf my fear. Every surgery that I faced, he made it seem like, okay, what next? And I would just look at him and say, okay, I'll see you there, but that's what I needed. And he knew that I needed that because he asked me one day, where do you get your strength from? I used to drive to appointments and he'd say, did you drive here today? And I'd be like, yeah, because I didn't have it. But it's key to have a support system. And if you can, to have it in place. It truly is.
What about for you, Glorby? What do you wish you had known before?
Gosh. I mean, for me, I wish I had known not to ignore my body. I ignored it for God knows how many months. Had I known what this could have been, like she said, plan ahead. This is something that when you get the news, you have to scatter and figure out what to do with, with your kids, with your family, with your job. Financially, it was such a burden financially. And that's something that I did not think of, health-wise. You think you're good. I feel good. I wake up, I'm fine. You really don't know until something like this hits you. So yeah, definitely, like she said, plan ahead, and if you do have that support system, you grab and you hold on to them.
Dr. Tanna, we know that you see a lot of women who are very sometimes unhappy with a prior breast reconstruction. Maybe it's an older type of breast reconstruction, or maybe it's a reconstruction that they're just not happy with. When women are unhappy with the results, I mean, how do you help these women? What are some of the things that you do to help women get back to a better, sometimes it's quality of life and sometimes it's self-image, or a combination of the both?
Yeah, no, I think it's important to have a discussion and understand what is bothering them, and then remind, everyone has to remember that it's stages, it's multiple stages. It's not all one, and on the flip side though, many women out there think that that's it, it's done, that it is what it is, and that there's no ability for improvement. And I think that's, again, one of those myths. So I think patients have to understand it is a process, but on the flip side, there are options. And even if you were told 6 months, a year, 5 years ago, you see how much things change. So, we're getting better and better, and just, see what options are out there. And I think in my lifetime, hopefully things will be even radically different than where we are today.
Mm-hmm. Sometimes we even see women come back many years later, maybe at their initial breast reconstruction, they decided they didn't want to have nipples. Sometimes it's not a choice, but sometimes it is. Can you give women nipples years later after their initial breast reconstruction?
Yeah, I think even that has come a long way. Nipple reconstruction, was traditionally thought of just as a tattoo. And now it's, we've got, surgical options followed by a 3D tattoo. So we've got a lot of options that have occurred. And oftentimes what we see is women who, sometimes doesn't want to pursue the nipple reconstruction may not feel completely satisfied with the rest of the breast reconstruction. So it's just important for someone to get knowledge. It doesn't, going to see a surgeon or going to see a treatment provider doesn't mean that you have to sign up for it, right? Knowledge is power. Just get out there and get the information, and just the same, get a second opinion if you need to. You're not doing anything but educating yourself. It's without commitment. So I think that's the most important thing for women to understand.
Mm-hmm. Dr. Tanna, you obviously, take such great care of your patients. I think, you go the extra mile to make sure that women have all the support resources that are necessary to go through this journey, not just on the clinical side, but on the emotional side, the spiritual side. You understand the whole journey. What is the most rewarding part of what you do every day?
It's taking care of women like Gloria and Joanne. It's their inspiration. You see, there's a word that was thrown out earlier today, resilience. And what is resilience? Resilience is the ability, it's the ability to overcome adversity. It's the human spirit. It's what defines all of us. And the reality is that every single one of us on this call tonight will face adversity, whether it's in the form of a mastectomy or breast cancer, or the loss of a loved one, or your own health, sickness, divorce, job loss. And it's the ability to overcome that. Resilience is a muscle. If you use it, you get better at it. And the elements of self-compassion, of community, these are the things that help build resilience. Every single one of us being on this call tonight helps us build our own resilience. So it is the people like Joanne and Gloria that really inspire us and teach us how to be better human beings. So again, it is personal and professional both. And so, that really sums it up.
Well, Dr. Tanna, thank you so much for, educating us tonight, for being part of a very intimate discussion that not only includes the clinical side of what you face every day, but hearing women and what they go through on the emotional side, yet, the positivity of how they come through their journey feeling positive. And as whole women, regardless of the type of breast reconstruction they have, but feeling good from the inside out and from the outside in. It has to go both ways, as we know. So with that, I'm going to let you go this evening, and we'll take these last 15 or 20 minutes to stay on with our members and our patient guest speakers and Angela to even take a little bit of a deeper dive into sometimes what women go through this journey. And you'll have an opportunity to ask our two patients, myself and Angela, anything that you want. In addition to that, we also have Nicole Stam, who is on the call with us tonight.
Thank you, guys. Thank
Dr.
you, Gloria.
Tanna, thank you so
Joanne.
much.
Great seeing you both.
Thank you.
Thank you.
Nicole Stam is with us tonight. She is our clinical care coordinator and nurse practitioner Maybe we can spotlight Nicole if you can find her in our audience, if that's okay, Nicole. If not, that's fine too. Oh, there you are. Hi, Nicole. So Nicole is very gracious to be on our monthly webinars with us to help answer any clinical questions that come up. So I encourage you to please ask us questions while it's us girls. Nicole, on the clinical side, I saw a question come in. What is Lynch syndrome? Is that something that you can answer for us?
I probably wouldn't be the best person to answer that,
Okay.
but Joanne can probably explain it better than I could.
Sure, I definitely can. So with the knowledge of Lynch syndrome, it is basically colon cancer gene, but with that, it is connected to many cancers. So to give you a little bit of enlightenment on it, my grandmother had 7 sisters. My grandmother had breast, her one sister had lung, the other one had colon, and we believe that her one sister actually had brain. And Lynch syndrome is connected to those many cancers. So by pinpointing that, unfortunately, like my grandmother was never tested for anything, and neither was my mom. My aunt was the only still living who has tested negative for BRCA, but also for Lynch, which is kind of, it's still a little bit of a shady area for us, but it has definitely come down from the maternal side. And it is, it is a very serious gene to be watched along with the breast cancer. And I go for my routine colonoscopies now, and, I just stay on top of it. But it is basically the colon cancer gene that is connected to lung, brain, breast, and colon.
Thank you, Joanne. Nicole, a question also came in earlier when we were showing the video about resensation. And the question is, what percentage of plastic surgeons are using this technique? We know not all of them are. There are some limitations, insurance issues, may not be recognized by insurance companies and so on. Can you give us a little info on that?
Sure. I don't know if I can really give a percentage,
Right, that's okay.
so to speak, but I think it's definitely a newer technology. There has been a significant amount of marketing behind it. So I think women are more aware that it is an option. It's definitely an option for women who are having reconstruction using their own tissue. I think it's even being used now for women who are using implant-based reconstruction. So it's something, if it's something that you're interested in, it's something that you should be bringing up to your plastic surgeon and seeing if you're a candidate for it first and foremost, and then finding out if that technique is something that your surgeon is comfortable performing. The technique itself is pretty routine. There's a material, as you saw in the video earlier, about how the nerves are connected, but definitely an option for most women. And you can speak to your surgeons about it more to see about the techniques and if you are a candidate.
Thank you, Nicole. We also have a question for Nicole. We have somebody who's exploring reconstruction next month. She's had 3 cesareans that have caused her abdomen to protrude and hang a bit. Would it be possible to use that fat to complete the reconstruction for her breasts?
Likely. A lot of abdominal surgeries, we can work around and use that tissue. It depends on what type of abdominal surgery. C-sections do not, create an issue for using that tissue. It's called a deep flap. The vessels that feed that tissue are not affected when you have a cesarean section. So typically you are able to use that tissue. If you had an abdominoplasty or a tummy tuck in the past, usually that makes you not a candidate for using that tissue. But again, something that would be reviewed during her consultation for her reconstruction. And then we would perform different imaging to assess the vascularity and the blood supply to that tissue after her appointment.
Okay. There's another question about in relation to implant breast reconstruction. Is there a risk of developing fibromyalgia?
I would say not typically. What's been associated with implants in the past is ALCL, but that's with textured implants, and most of those implants are not really used anymore. Typically, we're using smooth, round silicone implants for breast reconstruction. So not typically. But again, if you have other autoimmune issues, and it's something to be discussed with your breast reconstruction surgeon when you're planning out your treatment plan.
Mhm. Another question in regards to lymphedema, and I'm glad you're with us tonight. Thank you again, Nicole, because we do
Sure.
get a lot of clinical questions that are a bit more personalized, but it's great that you're here to help us, because it always helps somebody else in the audience as well. Are there any steps that women can take to help prevent lymphedema after breast reconstruction?
I think typically what we tell all patients is to, make sure you have a good nutrition and exercise regimen ahead of time. That just helps with, your circulation, your cholesterol, helps you to recover faster after surgery in general. Lymphedema is usually an issue when you have the lymph nodes affected during surgery. You either have them removed, or you have one node removed, or you have multiple. So it really depends on the surgery. There's not necessarily anything we can do to prevent it up front. It just depends on how much the breast surgeon needs to remove or excise during the procedure. But there are definitely things we can do to help it afterwards, and to hopefully keep it under control and manage it well. There are sleeves that are custom made for patients to wear afterwards. There's specific lymphedema physical therapy that we send patients for. So all sorts of things that we can do for afterwards.
Mm-hmm. Mm-hmm. Okay.
But unfortunately, it is an issue. So
we have another question about what does breast reconstruction follow-up look like, and how soon after is it safe to have a mammography? Now, sometimes mammography is actually not needed, but maybe you can explain a little bit further about that.
Sure. So mammograms are typically not needed after mastectomy. There's no breast tissue, or there is a certain amount of breast tissue. Mastectomies, I should clarify, they remove all of the breast tissue, but it's virtually impossible to remove everything. There's usually about 1 to 2% of breast tissue that's left behind. So there is no routine mammograms performed after mastectomy for screening purposes, because of the lack of breast tissue after that. But if you do have a lumpectomy, that would be discussed with how often you need screening mammograms or sonograms with your breast surgeon, and what the follow-up would be. It may look different. It may require MRIs and other sorts of imaging. It really just depends, but mammograms not typical for after mastectomy.
Okay.
And I think I didn't answer the beginning of that question. I don't know if
Yeah, you're good. Thank you. What about nerve damage? Nerve damage obviously happens at the time of mastectomy. Whether or not you've had a deep flap or implant, the nerves are still cut. Is there any risk to any further nerve damage if you've had a deep flap, like let's say in your feet or other extremities?
Not necessarily. The typical scenario we hear about neuropathy is related to chemotherapy. There's not really an increased risk of having nerve issues anywhere outside of the surgical area after deep flap reconstruction. Like you were saying about the nerves being cut from the mastectomy, we also work around sensory nerves in the abdomen if we use that tissue for reconstruction. So you will it's common to have some areas of numbness that may prolong for long periods of time. There may be some areas that are usually right below the belly button that you may not regain full sensation there, but after surgery, numbness right after is typical. It gets better, and everyone's different. Some people, they regain sensation pretty quickly. Other patients, they have different feelings of nerves regenerating. So shocks, pinching, any kind of like a weird sensation. Some patients actually get they feel numb, but they feel something is there, and they feel an itch that they can't scratch, which I see Gloria
Very bizarre feeling.
Shaking their head. So.
All the time.
Yeah.
All the time. I'm like, where's that itch?
Yes. It's like a dog going in circles.
It's like,
Yeah. And a lot of it ends up being referred from another area of the body or the breast. So a lot of times patients will feel it in one area and we'll say, scratch. If it's central, we'll say, try to scratch on the lateral side of your breast. That may help. And it a lot of times it's kind of desensitizing the skin and kind of helping your body adjust to the new normal that helps in the long run.
Mm-hmm. A question came in earlier about tissue expanders. And the question was, is there anything you can do to make them more comfortable? And it is a common thing that we hear. We hear it all the time. These tissue expanders are so uncomfortable. So Joanne, because you had tissue expanders actually twice, right? Is there anything you were able to do to help ease the uncomfortableness they can sometimes present?
It's pretty much a process as you go. I'm a very rare case, I would say, because I went through a complete mastectomy on Tylenol. And Dr. Tanna used to say, "You're not filling the scripts?" And I'd say, no, I don't need them. But that's just, some people can tolerate a certain amount of pain. And I'm just one of those people. So when it came to the tissue expanders, every time I was there and he'd fill me and I'd walk out the door and he'd say, "Go home and take Tylenol." And I'd say, "Oh, yeah," because I was always fine. So for me, the uncomfortableness was the bulkiness of it. And I'm going to be honest, I don't think there is much that you can. Just keep in your mind that it's temporary. And that's what I kept telling myself. It's temporary. It'll go away. I used to laugh. I say, "Oh, I could just rest my hands up here at a certain point." It's a temporary feel. It's for pain. I mean, again, I guess I'm a rare case to say that, oh, it doesn't really hurt. It can be painful. I know that my last fill, I did drive myself because I've driven myself to every other one by myself. And I pulled over on a Meadowbrook Parkway and called Dr. Tanner in complete panic mode. I was like, "Well, what is this? What am I feeling?" And he was like, "Oh, it finally hit me." But taking Tylenol for the uncomfortableness really is most that you can do.
Yeah.
Pressure is something that you can't avoid, unfortunately. But is it painful? No, it's just more uncomfortable. It really is.
I'm sure, Nicole, you hear this all the time from all of the patients that come through our center.
Yes. And I think it's just like a weird feeling to have that whole procedure going on in your body.
Yeah.
Sometimes we have patients take either Motrin or Advil or Tylenol before they come in if they're more sensitive to having their expanders filled. And I don't know, Joanne, if you had any garments that you wore while you had the tissue expanders in, just to give yourself a little bit more support so the weight of them wasn't affecting you while you're adjusting to the new volumes.
I did. I got myself into a comfortable, nice, supportive sports bra. I was tired of wearing the medical bra, and I put myself into that, and it worked. It was pretty comfortable for me. I slept in it. I really never took it off.
Yeah, I think sleeping in it helps a lot because then, when you're laying down, the gravity isn't kind of pulling on everything and affecting the muscle and everything. So that's good to know.
I think that if I can interrupt, one important thing that I'm so happy that a friend of mine who had just gone through the same exact process said to me, "You're going to need a recliner." I never thought about that while I sleep.
We like to recommend recliners.
I slept on that thing for months. I don't know what I would have done without it. So that's really probably some good advice, I would say, if you are going to go through the process. A recliner really puts you into a comfortable position, and it's helpful.
For a deep flap as well, I might add. I'm sure Glorby would agree.
Yes,
well, we are coming up on 7:30, and I would like to sincerely thank once again Glorby and Joanne for sharing such an open heart with us about your journey. It is something, this intimacy issue is something that keeps women up at night. And until they get to the other side where you ladies are now, it's so hard for women. And so to hear your inspiring stories has just been a blessing, I'm sure, for some of the ladies on this call. So thank you. And to Angela and the entire Adelphi group, thank you so much for partnering with us, for allowing us to be on your platform tonight to speak to the breast cancer community and patients. And Nicole, I always have to thank you for being my partner on the clinical side to help get us through these webinars and articulate the answers to some of these questions. Thank you, everyone. I'll just reiterate one more time. If you have any questions afterwards, please feel free to call us, email us. Our information is still in the chat box. And I thank you all for coming tonight.
Thank
Thank you.
you.
Thank you.
Thank you.